Good morning all. This is Dr. Sangeetha, mentors at StudyMEDIC and StudyMRCOG. And today I'm here to discuss about postpartum problems. Mainly I'll be discussing maternal sepsis and perinatal mental health problems. I'll be discussing SPS and EMQs on these two topics. So let's start. So let's first move on to maternal sepsis. Which antimicrobial agent should not be relied on empirical treatment where ESBL producing organisms are suspected in maternal sepsis? Answer is B. Ceftriaxone. Cephalosporins, example like ceftriaxone, has no activity against ESBL producing coliforms, Pseudomonas or MRSA. ESBL is extended spectrum beta lactamase, and cephalosporins covers beta hemolytic streptococci, including gas and GBS. It should not be used if there is severe beta-lactam allergy and it is associated with increased risk of Clostridium difficile infection. Vancomycin covers MRSA. It is the recommended option for GBS prophylaxis in patients with severe penicillin allergy. It has no coverage for gram-negative organisms. Gentamicin is mainly gram-negative cover, including most Pseudomonas. It has no streptococcal or anaerobic cover. Carbapenems covers most gram-negative, including ESBL producers. Anaerobes covers most gram-positive except MRSA. This is the antibiotic spectra given in the guideline. You can see that gentamicin covers MRSA, most gram-positive, gram-negative, and Pseudomonas. It has no action against anaerobes and group A and group B streptococcus. Penicillin covers most anaerobes, group A, group B streptococcus. No action against MRSA, gram-positive, and gram-negative organisms. Coamoxiclav covers anaerobes, gram-positive, group A, group B streptococcus, and most gram-negative. There's no action against MRSA and Pseudomonas. Cephalosporins have action against gram-positive, group A and group B streptococcus, most gram-negative. It has no cover against anaerobes, MRSA, and Pseudomonas. Tazocin, that is piperacillin tazobactam, meropenem, covers anaerobes, most gram-positive, group A, group B streptococcus, gram-negative, and Pseudomonas. No action against MRSA. Clindamycin covers anaerobes, MRSA, gram-positive, group A, group B streptococcus. No action against gram-negative and Pseudomonas. Vancomycin covers MRSA, gram-positive, group A, group B streptococcus. Astronome is mainly for Pseudomonas. The antibiotic given here in yellow is given orally for mild infections. This statement regarding clindamycin usage in maternal sepsis is correct. It is not effective in gas infection, renally excreted, no role in severe sepsis, switches off exotoxin production. 15% of GBS are resistant to clindamycin. Answer is D, switches off exotoxin. Clindamycin covers most gas and GBS, covers most staphylococci, including many MRSA and anaerobes. It switches off exotoxin production, thereby preventing the toxic shock syndrome. It is not renally excreted, hence not nephrotoxic. 11% of gas and 31% GBS are resistant to clindamycin. That's why it should not be used empirically for GBS prophylaxis or treatment unless organism is known to be sensitive. This is once again the antimicrobial spectra given in the green top guideline. Now, which statement regarding repeat lactate measurement in maternal sepsis is correct? The answer is C. It should be repeated if the initial lactate is 2 or more millimoles per liter. Serum lactate should be measured urgently in all women with features of sepsis. Lactate may be elevated by the physiological process of labor and due to other complications common in pregnancy such as bleeding. Lactate of 2 or more should initiate immediate senior review, intravenous fluid administration, and the repeat lactate has to be measured within 1 hour, mainly to assess the response to treatment. Lactate of 4 or more is indicative of tissue hypoperfusion or cellular metabolic dysfunction. This should prompt immediate escalation of care, consideration of discussion with critical care regarding ongoing care and intravenous fluid administration. Coming to question 4, a woman is reviewed 48 hours after cesarean section with severe wound pain. Examination shows minimal erythema, no obvious skin changes. Despite escalating analgesia, she now requires opioid medication for pain control. Which feature is most consistent with early necrotizing fasciitis? Answer is B, severe pain disproportionate to the clinical findings. Now, necrotizing fasciitis is infection causing necrosis of the superficial and deep tissue and subcutaneous tissue. The cardinal feature of early necrotizing fasciitis is agonizing pain, which is disproportionate to the clinical findings. Pain will be so severe that patient needs increasing amount of analgesia, ultimately culminating in opioids. In early necrotizing fasciitis, there may be no skin changes, but later on, once the infection spreads to the skin, it will produce blisters and frank necrosis. Incidence of necrotizing fasciitis is 1.8 per thousand cesarean birth, and most rapid and severe forms of necrotizing fasciitis are usually due to group A beta hemolytic streptococcus. What is the recommended initial fluid bolus for a woman with maternal sepsis and hypotension? Answer is B, 500 ml crystalloid. Early fluid resuscitation of crystalloid should be administered starting with a fluid bolus of 500 ml in women who are hypotensive or if the lactate is 4 or more. Further fluid boluses may be required based on the response. Ensure intensive care input if woman needs more than 2 liters of volume and if there is no improvement in hypotension. Women with preeclampsia or eclampsia due to increased risk of pulmonary edema require individual care guided by close anesthetic or critical care team. Now, this is the sepsis 6 bundle, which should be initiated within 1 hour of identifying sepsis. Measure lactate level, step 1. Step 2, obtain blood cultures before administering antibiotics. Step 3 is administer broad spectrum antibiotics. Step 4, begin rapid administration of 30 ml of crystalloid for hypotension or lactate 4 or more millimoles per liter. Apply vasopressors if hypotensive or after fluid resuscitation to maintain a mean arterial pressure of 65 or more. You have to remeasure the lactate within 1 hour if the initial lactate is elevated, that is, if it's more than 2. Influence of perineal colonization of group A beta hemolytic streptococci in pregnant women is the answer is B, 0.03 to 0.06%. Only 0.03 to 0.06% of pregnant women have perineal colonization with gas, and these women are usually asymptomatic. Why? Because the vaginal discharge is often watery and the leukocytes are destroyed by gas leukocidins. Hence, the discharge is not offensive, thereby delaying recognition. However, ascending vaginal gas can cause endometritis, myonecrosis, peritonitis, and streptococcal toxic shock syndrome. A 27-year-old woman presents 10 days postpartum with rapidly progressing breast infection requiring admission. She reports a long history of recurrent boils since adolescence and has multiple scars from previous incision and drainage procedures on her limbs. Which constitutive organism most strongly suggested by the history? Answer is C, PVL producing Staph aureus. PVL is Pantin Valentine leukocidin. It is produced by staph, and this organism particularly associated with mastitis and breast abscess. The organism can cause recurrent skin and soft tissue infection, so the patient will give a history of multiple incision and drainage. Now, these are the certain salient features regarding infection and the organisms. A woman present in the early postpartum period with sepsis of unclear origin. Her LFT shows ALT more than 10 times the upper limit of normal with normal bilirubin levels. What is the most appropriate next step? Answer is B. Start IV acyclovir while investigations are pending. Now, disseminated herpes simplex infection presents with sepsis, encephalitis, or hepatitis. It is rare but often fatal if contracted in the peripartum period. There are no clinical signs of disseminated herpetic infection, which can differentiate it from bacterial causes of infection. HSV should be considered as a causative agent in women where there is a failure of first-line antibacterial medication. Early IV acyclovir therapy is vital and should be started along with the first change in antimicrobial regime. Diagnosis should be considered if a pregnant woman presents with acute febrile hepatitis, as evidenced by markedly, that is more than 10 times raised ALT, but the bilirubin levels is normal. Encephalitis or disseminated or often vesicular skin lesions or a combination of this. Coming to the EMQs, these are the options for the questions 1 to 4. So let's start. EMQ1, a 34-year-old woman, 5 days postpartum, presents to the emergency unit with sudden confusion and agitation. Her examination findings are systolic BP 85, heart rate 132, respiratory rate 32 breaths per minute, and lactate is 3.1. The answer is E, start sepsis bundle and urgent review. Now, red flags are features in patients with suspected sepsis that indicate high risk of sepsis. These patients need immediate management either with initiation of sepsis 6 bundle for inpatients or referral by blue light transfer from the community. Signs include objective evidence of altered mental state, Glasgow Coma scale less than 15 or not alert in the AVPU classification. Respiratory rate is 25 or more breaths per minute, heart rate more than 130, systolic BP less than 90, patient has not passed urine in more than 12 hours, or if catheterized less than 0.5 ml per kg per urine per hour, if the lactate is 2 or more, and if she needs oxygen to keep SpO2 more than 92%. Red flag signs means you have to start the sepsis 6 bundle immediately. These are the table given in the table of red flag signs given in the green top guideline. So question 2, a 26-year-old woman, 2 days post-cesarean section reports of increasing abdominal pain. She appears unwell. Observation show respiratory rate 22 breaths per minute, heart rate 120, temperature 38, blood pressure 170, oxygen saturation is 96% of air. Answer is D, amber flags present. So urgent senior clinical review within 1 hour for inpatients or as soon as possible in the community. Now, this is the table regarding the amber flags or features in patients with suspected sepsis. Amber flags suggest moderate risk of sepsis and it warrants senior clinical review within 1 hour for inpatients or as soon as possible in the community. Signs include behavioral or mental status change, acute deterioration in functional ability, respiratory rate 21 to 24 breaths per minute, heart rate 100 to 130, systolic BP 91 to 100, urine output if she has not passed urine in past 12 hours, or if catheterized 0.5 to 1 ml per kg urine per hour. If she hasn't had an invasive procedure in the last 6 weeks like cesarean birth, assisted vaginal delivery, surgical management of miscarriage, circular, serious amniocentesis, miscarriage or termination. If she has an impaired immune system due to illness like HIV or she's on long-term medications like oral steroids, temperature less than 36 or more than 38, current diabetes or gestational diabetes, close contact with gas, prolonged rupture of membranes 18 to 24 hours, prolonged vaginal bleeding and abdominal pain after birth, offensive vaginal discharge. Question 3, a 34-year-old woman 4 days post-delivery appears seriously unwell during a home postnatal visit. She's pale, distressed and complaining of worsening abdominal pain. The midwife is concerned. Answer is H, immediate referral via ambulance services. If sepsis is suspected in the community, such patients need urgent escalation and referral to the hospital, and referral should be made by emergency ambulance services. MQ4, a 30-year-old woman, 3 days postpartum reports to the community midwife about having abdominal pain and persistent vaginal bleeding. She does not appear systemically unwell and is febrile. Pain has not improved since delivery. Answer is F, urgent referral to hospital for assessment. Post-delivery streptococcal infection, especially gas, is most likely to present within 12 hours after delivery. Infection should be suspected and actively ruled out for women who have recently given birth and experienced significant abdominal pain or persistent vaginal bleeding. Usually after pains after a vaginal delivery should reduce. It should not persist or worsen after discharge. And if the patient is seriously unwell, she should be referred by an emergency ambulance. Pain after a vaginal birth that does not settle with simple analgesia should prompt a face-to-face review and a clinical examination, including both abdominal and vaginal examination if indicated. This is the chart on red flag signs and the amber flag signs. This is the sepsis 6 bundle. All action should be completed within 1 hour. Step 1 is ensure senior clinical review. Step 2, start oxygen if O2 saturation is less than 92%. Step 3, obtain IV access and take blood. Step 4, give IV antibiotics. Step 5, give IV fluids. And step 6 is monitor on the Muse chart. Coming to EMQs 5 to 7, these are the options. Question 5, a 29-year-old woman at 32 weeks gestation presents with profuse diarrhea, abdominal pain and fever. She completed a course of broad-spectrum antibiotics 10 days ago for pyelonephritis. What is the most likely organism? Answer is G. Clostridium difficile infection. Any diarrhea following antimicrobial therapy is suggestive of Clostridium difficile infection. Toxic megacolon, perforation and septic shock are life-threatening CDI complications. Treatment is oral vancomycin. Vancomycin is not absorbed orally, so it's always given IV except for treating Clostridial difficile infection. A 26-year-old woman with 30 weeks gestation presents with fever, myalgia, and diarrhea. She reports eating unpasteurized soft cheese 5 days ago. What is the most likely causative organism? Answer is H. Listeria monocytogenes. Listeria infection is transmitted through consumption of unpasteurized milk, undercooked or cured meats. Maternal symptoms can be mild flu-like symptoms like fever, myalgia, abdominal pain, and diarrhea, but it can cause serious fetal effects like fetal loss, preterm birth, neonatal sepsis, meningitis, and death. Which organism is associated with cavitating pneumonia, hemoptysis, and rapid collapse in the peripartum period? Answer is both A and B. Both gas exotoxins and PVL producing Staph aureus can produce a secondary necrotizing hemorrhagic pneumonia with severe respiratory compromise and a high mortality rate. Hemoptysis, rapid clinical deterioration, cavitation, and massive effusions all are features of necrotizing pneumonia. Now let's discuss the next topic, perinatal mental health. Coming to the SBS, what is the incidence of mental health problem in perinatal period? Answer is C, 1 in 5. At least 1 in 5 women experience a mental health problem in the perinatal period. Anxiety and depression are the commonest psychiatric problems during pregnancy. 12% experience anxiety and 13% experience depression. The incidence of postnatal depression is 15 to 20%. The most common psychiatric complication of postnatal period is adjustment disorder. Incidence is 1 in 4 women. Coming to question 2, according to Embrace UK 2025 report, what percentage of maternal deaths were from mental health related causes? Answer is C, 34%. According to Embrace 2025, 34% of maternal deaths occurred due to psychiatric causes, and with maternal suicide as the most common direct cause of maternal death in the first year postpartum. Coming to question 3, considering the legal frameworks to perinatal mental health, temporary detention of patients with suspected mental health disorder to allow for a formal MHA assessment under Section 5.2 of Mental Health Act is limited to 24 hours, 48 hours, 72 hours, 28 days, 6 months. Answer is C, 72 hours. Section 5.2 of Mental Health Act is also known as the doctor's holding powers. It is used for patients with a suspected mental health disorder who request to leave a general hospital ward, resulting in a temporary hold for up to 72 hours to allow for a formal MHA assessment. It can be used by fully registered doctors F2 and above. It does not allow treatment to be given. Section 5.2, as I said, doctors holding powers. It is mainly used when an inpatient with a mental health disorder who wants to leave the hospital. In such cases, if the doctor finds that this patient is at risk for herself and for the community, he can temporarily hold this patient for 72 hours to allow for a mental health assessment. Section 2 of MHA allows for the compulsory detention for assessment and or treatment for up to 28 days, while Section 3 is used for treatment for up to 6 months. A 32-year-old woman on the postnatal ward is displaying severe mood fluctuation. She's displaying an elevated mood, energy, activity, and on other occasions, low mood, decreased energy and activity. She is requesting discharge from the hospital. Which legal framework is the preferred initial course of action? Answer is E, Section 5.2 of MHA. The Mental Health Capacity Act is designed to protect people aged 16 and over who may lack capacity to make decisions about the care. Deprivation of liberty safeguards are legal protections under the Mental Capacity Act for adults 18 plus in hospitals or care homes who lack mental capacity and whose care involves restricting their freedom, depriving them of their liberty to keep them safe from harm. Regarding the presentation of perinatal mental health problems, answer is B. OCD symptoms are particularly focused on the baby. Perinatal obsessive compulsive disorder affects 2 to 100 in women in pregnancy and 2 to 3 per 100 women in postpartum period. It is characterized by obsession, recurring intrusive thoughts or images, anxiety and distress, compulsions, that is repeated or ritualized thoughts or actions to decrease anxiety like washing or checking. Symptoms are often focused on the baby. These thoughts can sometimes be distressing and appear psychotic nature and best assessed by specialists. It can be sometimes severe enough requiring inpatient admission. Treatment is cognitive behavioral therapy and medications. Now, complex post-traumatic stress disorder shares features with borderline personality disorders and requires specialist team to differentiate. Anxiety disorders affects 13% of the women antenatally and 15 to 20% experience postnatally. Question 6. Women with sudden onset postpartum psychosis should receive specialist assessment within 24 hours, 48 hours, 4 hours, 8 hours. Answer is C, 4 hours. According to NICE guidance, if a woman has sudden onset of symptoms of psychosis, she has to be referred to a secondary mental health service, preferably a specialist perinatal mental health service for urgent assessment. And this should occur within 4 hours of referral because puerperal psychosis can progress very quickly. Which complication is associated with SSRI use at higher dose in pregnancy? Answer is B, persistent pulmonary hypertension. SSRI are the first-line drugs for depression and anxiety disorders. Drugs include citalopram, fluoxetine, paroxetine, and sertraline. It can cause persistent pulmonary hypertension in newborn if used after 20 weeks, and it can cause neonatal adaptation syndrome, which is mild and self-limiting. A 29-year-old woman who takes lithium for bipolar disorder is admitted in labor at 38 weeks gestation. What is the recommended approach for lithium management in labor for her? Answer is stop lithium and check plasma levels 12 hours after the last dose. Now, lithium is a mood stabilizing agent and it should be withheld during labor, and plasma levels should be checked 12 hours after the last dose. Lithium toxicity arises due to dehydration and rapid fluid shifts after delivery. Ensure monitoring by the obstetric team when labor starts, and including checking plasma lithium levels and fluid balance because of the risk of dehydration and lithium toxicity. When using lithium during pregnancy, the level should be checked every 4 weeks, and after 36 weeks, it should be checked weekly. Coming to the EMQs. These are the options for questions 1 to 4. EMQ1, a woman who delivered 4 days ago reports tearfulness, emotional lability, and exhaustion. She's bonding well with her baby, retains insight, and symptoms fluctuate during the day. Answer is postpartum blues. A. Postpartum blues are also called as baby blues. These are the common self-limiting emotional state occurring in the immediate postpartum period. It's not a mental illness and does not require medical treatment. Affects 50 to 80% of women after childbirth. Typically occurs in women without prior psychiatric illness. Onset is usually 2 to 3 days postpartum, peaks around day 4 to 5, and most of the time it spontaneously resolves by 10 to 14 days postpartum. If it persists beyond 2 weeks, you have to assess for postnatal depression or other disorders. Typical features of postpartum blues include tearfulness, emotional lability, irritability, anxiety, low mood, fatigue, being overwhelmed. Key distinguishing features is that the insight is preserved, mood fluctuates during the day, she has the ability to enjoy with the baby, there's no psychotic symptoms and no suicidal ideation. Question 2. A 29-year-old woman is reviewed 7 days after delivery because the family is concerned about her behavior. Over the past 24 hours, she has become sleep deprived, restless, and increasingly confused. She's talking rapidly, expressing bizarre beliefs that her baby is in danger, and reports hearing voices telling her to stay awake. Her mood is labile and her insight is impaired. There's no evidence of infection or substance misuse. Answer is E. Puerperal psychosis. It's a severe mental illness and it's a psychiatric emergency that occurs suddenly in the immediate postpartum period and requires urgent specialist care. Incidence is 1 to 2 per 1,000 birth. Risk factors include previous puerperal psychosis, recurrent risk is up to 50%, bipolar affective disorder, first degree family history of bipolar disorder or puerperal psychosis. Onset is usually within 2 weeks postpartum. There is rapid deterioration. Symptoms may be non-specific initially and they evolve rapidly. Early symptoms include severe insomnia, anxiety, irritability, mood lability, perplexity, or confusion. There will be psychotic symptoms like delusions and hallucinations, can be features of mania or mixed affective features, disorganized behavior, and impaired insight. MQ3, a 32-year-old woman attends her GP 6 weeks after delivery complaining of persistent low mood, overwhelming feelings of guilt about being a bad mother. She reports poor concentration, fatigue not relieved by rest, and reduced enjoyment when caring for her baby. These symptoms have been present most days for over 3 weeks. She denies psychotic symptoms, has no thoughts of harming herself or her baby. Answer is C, postnatal depression, which is a depressive episode occurring after childbirth and typically occurs within few days postpartum, meeting standard diagnostic criteria. Affects 10 to 15% of postnatal women, can occur at any point in the first year after birth. Onset is usually from 2 weeks postpartum. Symptoms, if it persists beyond 10 to 14 days, needs prompt assessment. Earlier onset may occur, but it should be differentiated from postpartum blues. Clinical features include core depressive symptoms, which is present for most of the days for more than 2 weeks. This include persistent low mood, anhedonia, that is loss of interest or pleasure. Associated features include fatigue, poor concentration, guilt or feelings of worthlessness, sleep disturbances, appetite change, suicidal thoughts or acts of self-harm. Coming to MQ4, a 28-year-old woman presents 4 weeks postpartum with low mood, tearfulness, anxiety following an emergency cesarean section and breastfeeding difficulties. She reports feeling overwhelmed but continues to care for her baby. There is no anhedonia, suicidal ideation, and symptoms begin after the delivery related stresses. She has preserved insight and no psychotic features. Answer is B, adjustment disorder. Adjustment disorder is the commonest psychiatric complication of postnatal period. Usually affects 1 in 4 women. The symptoms are characterized by a psychosocial stressor or its consequences like birth and matrescence and include excessive worry, ruminations about birth or baby, and difficulty with adaptation to mothering, causing significant impairment in personal, family, or social function. Does not meet the criteria for depression, and symptoms usually emerge in a month and typically resolve in 6 months. No specific pharmacological treatment is required, can be managed with talking therapies and support, but sometimes it can evolve into acute mood or anxiety disorder. Coming to the EMQs, EMQs 5 to 8, these are the options. So let's begin with EMQ 5. A woman 10 days postpartum with rapidly evolving psychotic symptoms, severe insomnia, and inability to care for her baby. Which is the most appropriate next step? Answer is D, urgent admission to mother and baby unit. Now, mother and baby units are specialist inpatient units for women with mental health problems and their babies. Women with complex or severe mental health problems like postpartum psychosis, bipolar disorder, schizophrenia, severe depression, and anxiety will require admission in an MBU. And most cases, women are admitted postpartum within 12 months of childbirth. Admissions can occur in the final weeks of pregnancy. MBU, the advantage is you can keep the patient with a mental health problem as inpatient, and at the same time, the bonding with the baby will be kept intact. A 30-year-old woman is 18 weeks pregnant. She has a history of postpartum psychosis after first delivery, requiring MBU admission. She's currently asymptomatic and not on any medications. Answer is A, referral to specialist perinatal mental health services. Specialist perinatal mental health team this is a multidisciplinary team including psychiatrists, psychologists, mental health nurses, occupational workers. So indications for referral include women with current illness where there are symptoms of psychosis, severe anxiety, severe depression, suicidality, self-neglect and harm to others, women with history of bipolar disorders or schizophrenia, women with previous serious postpartum mental health illness like pubertal psychosis, and women on complex psychotropic medications. Question 7. A woman 2 weeks postpartum initially reported mild anxiety but now presents with agitation, confusion, paranoia, and poor sleep. What is the most appropriate action? Answer is B. Urgent psychiatric assessment. Rapid change in mental state is a red flag sign. Red flag signs are features that indicate suicide risk, and their presence should prompt urgent specialist assessment. Some of the red flag signs are recent significant changes in mental state or emergence of new symptoms, which can include psychotic symptoms like delusions or hallucinations, or severe anxiety in relation to the infant, new thoughts or acts of violent self-harm, new and persistent expressions of incompetency or estrangement from the infant, pervasive guilt or hopelessness, and severe insomnia. All these indicate urgent specialist assessment. Question 8. A 30-year-old woman with bipolar affective disorder is well on lithium and is planning a pregnancy. She requests advice regarding relapse risk medication and antenatal planning. What is the most appropriate action for her? Answer is E. Referral via perinatal mental health care pathways. Perinatal mental health care pathways ensure timely access to evidence-based care for women experiencing mental health problems during pregnancy and first 12 months after childbirth. Now, there are 5 pathways. Pathway 1 is mainly for preconception advice, that is, women with complex or severe mental health illness, current or past, planning a pregnancy. These patients will be referred by the perinatal mental health care pathway 1. Pathway 2 is for specialist assessment for women with known or suspected complex perinatal mental health problems. Even if she is currently well, she requires specialist assessment. Pathway 3 is emergency assessment for women with suspected perinatal mental health crisis like psychosis or if there is any rapid deterioration in her mental health. Pathway 4 is psychological intervention, non-emergency, known or suspected disorder suitable for psychological intervention. Pathway 5 is inpatient, that is urgent admission to MBU, mother and baby unit. It is for patients who require urgent unplanned inpatient care for a perinatal mental health problem. So pathway 1 is for planning, that is preconception advice. Pathway 2 is specialist assessment. Pathway 3 is for mental health crisis. Pathway 4 is for therapy, and pathway 5 is for inpatient, that is MBU admission. So these are the questions. This is a chart regarding the perinatal mental health care pathways. So I hope I have helped you with these questions in the 2 important topics, maternal sepsis, perinatal mental health. I wish you all the best for the upcoming MRCOG 2 exams. Thank you.